new every time I come here. So great. I'm just more fearful of radiation now, actually, than I was before. That actually jives well into my talk. If you could present it. And I laugh at that, but surgeons, our occupation is pretty hazardous. I mean, the rate of shoulder injuries, wrist injuries, carpal tunnel, cervical radiculopathy, multiple times higher than the normal population. Is because we're still the only manual surgeons here. We turn everything with our hands. So let me see here. I was expecting someone to put the presentation up. I guess I have to do it myself. So here we go. So, my talk is a little bit different and yet the same. It's on 3D navigated lateral L5-S1 ALIF. Now, I'm a big fan of navigation for all anterior or lateral surgery now. Again, the biggest thing for me is I don't like to wear lead. And I find I'm more efficient. It's accurate. Again, you don't want to blindly follow it, but it actually facilitates an operation. And I feel I'm safer because I can see the surrounding anatomy, and particularly with ALIF, the vasculature is very important, right? So here are my disclosures. So indications for a lateral ALIF at 5-1, same for supine, no difference, right? So same, a lot of people like ALIFs because you get big cage in, you get good disc height restoration, you get good anatomic realignment, lordosis. Everybody, I think no one questions it's a good operation. Lateral ALIF just eliminates the need for repositioning. So if you're doing like L2 to 5 L lifts, you do the L5-S1 ALIF in the same sitting, for example. It's just more efficient than going from supine to lateral. Or you could also put screws in as well. And so this is the most important point, right? I'm not a vascular surgeon, not a general surgeon. I feel like I'm fairly experienced in this area because I've done a lot of cases. But again, if I have a vascular injury, I'm not as good as a vascular surgeon. So if you're going to do your own approach, have to be very careful. And like so many things in surgery, selection, right? Select the right patient, you minimize the risk. And so, I started off doing this procedure with a general surgeon and vascular surgeon. So do enough case, you get a little comfortable with anatomy, and then you sort of branch off on your own. And so for me, if the vascular anatomy, high bifurcation, I can do it. There's minimal manipulation of the vasculature. Even with the lower bifurcation, if there's a good fat plane, you get a sense of that on the MRI, it's doable. It'll move. And so this is sort of extremes examples. Look at A. There's no vasculature at all, right, on MRI for the most part. I can do this approach safely, right? You look at the CT angiography, I mean, there's no vessel even close, right? I could be way off the midline and not a danger. And surprisingly, there's a fair number of patients with this sort of vascular anatomy. Panel B and D, it's a no-go for me, for sure. I mean, I'm not going to even think about it, right? So look at the MRI. I often get a CT angio too because it'll give you an idea of the calcification of the vessels, and that's an important metric as well. And osteophytes. Osteophytes are a big deal. If you see an osteophyte next to a vessel, I'm not going to tackle it on my own. It gets too sticky. But if you get this sort of presentation, I think it's a very straightforward operation, particularly if you do a lot of laterals. So this, I'm going to go through sort of steps. This is not my own studies. This was published in the European Spine Journal by multiple authors who are very experienced, Aaron Buckland, Alex Thomas, Brian Kwan. They're authors for this. And they go through this fluoroscopic-based procedure, and I don't like it because I don't like fluoroscopy. And I also don't like the bed positioning here. And I'll explain why. So the important point here is if you do a lot of laterals, you know how to tape and secure the patient. That's this, right? But I'm going to highlight this because you need the taping to expose the inferior, abdominal region so you can get the appropriate trajectory. So positioning is very important, right? Selection and positioning is like 50% of the operation. If you do it improperly, it'll make the operation possible or technically challenging. You don't want that, right? Position the patient well. So taping is very important. And if you can see here, this is a Jackson flat table. You use any OR table, but the problem is if you want to do a single position operation, you have to have it lined like this where the back is flush with the table. Otherwise, the downward screws, you can't get the medial trajectory, right? So that's a problem here on the anterior approach because the belly is sitting on this and you can't pull it down as much because you're pulling against the table, right? It's better to have it hang free, but then you can't put the screws in, right? This is where like a bed attachment is very helpful, like a specialized bed attachment. I'll show you some examples of that. Okay, so but this is a typical positioning for it. And they have a very nice diagram. So they have all these A, B, C, D, whatever, whatnot. The important point here, A to D, is just in line with the sacral end plate, okay? C is the top of the iliac crest, not important. B is the medial border of the iliac crest. You can palpate that, okay? And so you're gonna put an incision, and you can palpate the lateral rectus muscle or anterior rectus muscle and just a lateral border of that. And you want to center incision in that vicinity, okay? And the incision is about 2.5 inches, not big, right? And this just gives you an overview of where it is on the vasculature. This is a key approach. If you do a lot of laterals, it's not going to be unfamiliar to you. The only difference is when you're lower down the abdomen, perimedian, sometimes you don't see the external oblique muscle. What you see is an aponeurosis, because the external oblique muscle sometimes peters out and becomes just a fibrotic band toward the midline. So don't be surprised if you get through subcutaneous tissue, you don't see muscle. You may just see a fibrotic aponeurosis. That's okay. You just split that. Then the internal oblique muscle is your next layer typically. But again, you may just see an aponeurosis and that's it. And you see preperitoneal fat when you get through. And there's no third layer muscle. It's a transversalis fascia. It's like any sort of transversalis fascia. It's really weak, so you may not really even see it. But you tend to see preperitoneal fat. It's your guideline. Peritoneum is a pinkish structure. Sometimes very easy to violate, and I've violated it myself, and then you're just transperitoneal. But often it's robust enough that when you see preperitoneal fat, you just put your finger down, hook your finger up, and you follow the abdominal musculature. I just use my right hand, and this is this motion here. I'll show you in the lab. And you feel the ilium. It's not going to be far away. Once you feel the ilium, you kind of dissect off the ilium just with your finger. You'll feel that there's a little muscle on it. Then you just turn your hand and pull. Then you'll feel the psoas muscle here, right here. And then on the psoas muscle, you'll feel it's a tubular structure. It feels like tuba muscle. And you just follow it on the anterior border, and then you palpate the iliac artery. Right? You're not seeing anything here. You're just palpation. It's very noticeable. You just don't want to injure it, obviously, but it's very noticeable. You palpate it, and then you just pull, and you'll feel the sacral promontory. Then you just put a retractor in at that point, the downward retractor, and they have a specialized retractor for it. And you just follow it down and just provisionally lock it into place to hold that retraction. Then you put your secondary retractor in, and I'll show you through the lab, and I have some slides that represent that, but it's actually much more straightforward than you think. As long as you don't have to deal with the vessels of the promontory, so you pick your first patient, it has a high bifurcation, you'll see it's very straightforward. It takes like 5 minutes or 10 minutes sometimes. And so this is their view. They use a half-ring retractor here, and this is their initial retraction. This is usually what it looks like, but then you could fiddle with it and get something like this. But this is a typical view. Okay. And the only add-on or addition I would have to that particular approach, and they do a very good job with the fluoroscopic-based approaches, I use navigation. And so we've talked about navigation at length, and we know it's accurate. It's widely available now. A lot of people use it for screws, but it can be so much more, right? And so that's my sort of push for using navigation because it lowers that adoption barrier. Because you can see all the surrounding anatomy. It gives you some comfort during the approach as well. And again, we talked about radiation ad nauseum. I don't wear lead during this procedure. I often don't even get a picture until the cage is in a lot of times, unless I think there's something off. And so, Andrew went through a great prone lateral thing. I've been using it for laterals for over a decade now, so I'm a big fan of it. I feel it's very accurate. So often I don't take a picture until the cage is placed unless something seems a little off for me. And so that's for your standard L2 to L5 or T12 to L5 or thoracolumbar. I've done it at multiple levels. Published a bunch of papers on it, feasibility 15, accuracy in 16, then decreased radiation 17. It got tiresome, and so I stopped publishing. But I know it works. So I'll give you a couple of case examples. 68-year-old man, severe radiating right leg pain, minimal back pain, just radiculopathy, right? Under right L4-5 decompression without relief. So here's his MRI, and I can tell you he's got scoliosis, and it's a fractional curve problem. So they tried decompression only, it didn't really work, okay? And you can see the problem right here, right? This is in supine, and contralateral side looks fine. The right side is a problem. It's just from collapse. You can see scoliosis x-rays. It doesn't have a horrible curve, but you can see it's a fractional curve problem right here. And you can see the CT here, right? He's collapsed with 5. His TP is actually touching the sacroiliac because he's collapsed a fair amount. Now, I mean, you could argue, you could try a foraminoplasty or whatever you want. I just don't think it works very well for here. It's just a collapse problem. It's a structural problem. So if you take more bone away, it'll just collapse more over time, right? It's already collapsed so much that the TP of 5 is touching the ala, okay? And this is a perfect, I think, case for an interbody of some sort. You can do an MIST lift here, fine. But I think ALIF just gives you much more robust height restoration. So this is a position. This is the bed position. It's the same one Andrew was talking about earlier today. And so they have one for prone, they have one for lateral. And I love this positioner because not only does it get you in the right orientation and you could break it on a Jackson flat, so it goes right over the frame, but you can slide it back and forth. So you could slide this whole patient, the whole bed attachment, all the way back. Then you can slide it all the way forward. And we slide it all the way forward like I have in this position, belly hangs free. Okay, this guy's pretty thin, but I'll give you another example where the belly's really actually robust and just hangs off. So you can move it back and forth, okay? And so here I have the patient positioned, and you can see I'm using nav. There's no fluoroscope here in the field of view at all. So I'm just using nav for the skin incision right here. And you can see here's a skin projection here. I just project a point, 200 millimeters, and that's midline, right? Here's, this is about a 2.5-inch incision. Again, I centered it based on nav. And this is an aponeurosis. I don't really see too much muscle here. It's off to the side. And so I'm just going to open that layer. And so this is a nav pointer. I always put it in just, it gives me an idea where I am. If I'm not sure, I just put it in and I go, oh, I'm going to psoas. I can feel it, but if you just want confirmation of that, right? So this is just preperitoneal, retroperitoneal fat here. And, it's not great taking pictures because all you see is fat for the most part until you have the retractor situated. But here's a little bit of a video, and I'm going to show you, this pointer is right on the iliac artery. And I'm sorry, it doesn't magnify very well, but you can see the palpation. Hopefully you can see it if it'll play. Okay, so I'm going to point out, this is pulsating right here. This is the iliac artery. You can see it moving, right? It's pulsating a little. And so that gives me a guideline. I know I could just pull from there, and I could palpate the sacropromontory. And here's the view. There's a sacropromontory. I just only have 2 retractors in. So this is the downside retractor. And this doesn't have a lip on it. And it's just designed to kind of settle into that space between the iliac artery and vein and the anterolateral margin of the vertebral body. And the ipsilateral retractor here has a lip to it to pull up because, gravity. And in this case, it's a high bifurcation, right? I saw that in preoperative imaging. So I only need 2 retractors in. And this is your 5-1 disc space. Very straightforward approach here. And this is just, now I'm just navving this, right? So you got nav. This is a rotate distractor if you want to. If this space is pretty big, it breaks up the disc. And here's some instruments here. And here's a trowel going in. And, it's angled instruments. And you can see here's a pointer. So I know I'm in midline here. It's really actually pretty nice to see all that. And you can see how far back I am on the disc space. And this is the actual cage going in here. And here's the cage visualized. And here, here's I got an O-arm spin afterwards, and you can see the cage very accurate, right? Exactly where we position it on the trial. And more importantly, look at here, the collapse here, and look how open it is. You get tons of height restoration, and his radiculopathy was resolved after the procedure. I mean, no issues, and it was horrendous pre-op. So I'll give you another example, a little bit more complicated situation. 69-year-old L4-5 fusion, historically bad back pain, bad leg pain. He's got a flat back, you see here. So I decided to do multi-level laterals and ALIF here at 5-1. And so I just wanted to do everything in a single position. You see all the vacuum discs. This is great for interbody work, right? And so I'm not going to belabor the point, but he's got a little bit of a scoliosis and just a completely flat back. And this is where it's important. He's a bigger guy, right? So here, you can see where he's on the table. Then I move it forward, and his belly hangs off with a bed positioner. And again, I just marked this visually, but I kind of eyeball where I think this was going to go, but this isn't real because I'm going to nab the skin incision, right? And so I was just, I think, talking to a fellow about what the landmarks would be. And if we were using nav, this is kind of where I'd probably center it. But we have nav, so why bother? So I don't go through the whole approach, but in this case, I use a third retractor just because the bifurcation is a little bit lower. But sort of same principle here. You got angled instruments for nav. And here's the trial. And I'm putting a small size trial and then a medium size. You can see I'm on point here. It's all medial, right? All in the midline. And then somehow, and I just showed this is I don't know what I was thinking, but this is off midline now. This is the actual cage itself. I think as I was tapping it in, I wasn't really paying too much attention. It looked good to me, but I'm off midline. You can see that. I mean, it's still well within the boundaries of this space. And I'm pointing that out because, afterwards it's a little off. And it's just, I was not really paying attention too much. But nav was accurate here. All I'm saying is nav is very accurate. The trials were midline, and for whatever reason, when I put the cage in, I didn't put it in midline. But, very versatile approach. And, we'll go to the lab to demonstrate it. But I think 3D nav for laterals and now ALIF in the lateral position is something that I think can really help you as a surgeon. And to me, it lowered the adoption of me doing it on my own because I could see the relevant anatomy during an approach, and it really does minimize, radiation exposure. So, thank you.
Paul, quick question for you. I think super innovative to do your own approaches. Did you initially start with a vascular surgeon being on standby, or did you just go for it?
Yeah, so for many years, I worked with just a surgeon, like a general surgeon or vascular, whoever's available.
Yeah.
And I think you get, anyone who does a lot of ALIFs I think, are very careful when it comes to vascular anatomy, obviously. But you always have that comfort level with an access surgeon, right? I think it's something if you want to do it, you can. But again, it just comes down to if the vasculature looks questionable, I just won't do it. But yeah, I started off working with different surgeons over the years.
And then my second question, you mentioned that the cage was not perfect to you. What is, because I personally actually like to have, for example, if you have the right-sided collapse of the foramen, I typically actually put the cage intentionally a little bit more to the right. Yeah. Or if you're in a fractional curve, that you kind of push it, into the side, there's more collapse. Or is it for you always center? Always.
Yeah, I mean, people do that. I mean, for me, I more wanted to point out that the cage looked a little off midline, but it's very accurate because Nav showed it on the final cage placement. That was my only point, is the accuracy was actually spot on. At first, I got the picture, I'm going, oh, I thought I had it midline. And then I went back, I go, actually, when I put the cage in, I wasn't paying attention. It inadvertently went a little off. So, as I was mounting it in, I just think it slid a little bit. I didn't realize it. So that's the only thing I was pointing out, because I'm trying to make an argument. And now I'm clearly biased. I like Nav. I was just saying Nav was very accurate there.
Yeah. So, but in your practice, do you sometimes position it a little bit off-center?
Sometimes the cage, yeah.
Intentionally, not.
Yeah, occasionally. But when you're using at an ALIF in particular, they're wide enough that I think centering it just tends to correct everything. But you're right. I mean, you could, if you're using a smaller cage, like putting it in the left or right, depending on a coronal malalignment, is a good idea. Yes.
So great talk. I had two questions. One is, when you're doing your approach, I guess you're splitting the muscle rather than finding the plane, like when we do that with an approach surgeon. Is that correct? And if so, what do you close when you're coming out?
You just close the surface level as an aponeurosis. I just closed that with a Proli.
But you're splitting. You're not finding that plane.
I'm cutting it.
Okay.
I'm not cutting. I'm not puncturing it, because I did that once. And it was transperineal. Okay. Actually, I didn't realize I was transperineal until I got in with the retractor. I just see bowel everywhere. I just have to tell you that. And it was very disconcerting to me. I was thinking about aborting, and then I'm like, I could try it. But there's just bowel everywhere. And then on the, when you get to the sacral promontory, you have to go through the other layer of the perineum. And the whole time I was thinking, maybe I should just back off. But it seemed like it was okay, so I just went through it, and patient did fine. I thought she didn't even get an ileus, and So.
Yeah, no, that's, I'm sure, because I mean, there's some places that do transperitoneal approach regularly, like that's their go-to.
I mean, I think there's nothing wrong. That's what gave me faith to do it,
Yeah.
even though it wasn't the plan.
No, that makes sense. And then my second question is, when you're malleting your cage in, it's nice when the patient's supine because you can just really go to town if it's super collapsed. I saw both cases here, big disc spaces. Have you had experience with doing doing a lateral position ALIF in a collapsed disc, and do you get enough force?
Yeah, so you could have someone push on the small of the back, and this is actually not that big of a disc space if you look at it, 5'1".
Yeah, true.
I mean, it's not completely collapsed, but if you could have someone just kind of push on the thing, and this other table actually has a backstop to it. The positioner, let me show it to you. Let me go back to, so this isn't a good example, but you could actually put a backstop to it a little bit. But yeah, have someone push on it.
If you do it with the on a flat Jackson, if you do it with a flat Jackson, there's this thing called a kidney pad where you can basically put bolsters in the back, so it basically gives you a backstop. Because I mean, if you don't do that with a collapsed space, it gets real difficult. And I know other people they do with a pegboard. That's what orthopedics do with like hips, and so that's like some of that interdisciplinary experience. But yeah, you definitely need a backstop to hammer against. Otherwise, you'll be struggling.
Yeah, and now that actually you mentioned, I was thinking back. There's a case way back that I had the same period. I actually couldn't get anything in. Even the cob was a challenge, and because it moved. And I think part of it, and like now I think about it, is like I wasn't using a bed. This is years ago, and we just had a Jackson flat table, and it was a thinner person, so they're not robust at all. So when you mallet, they move with, and even with someone pushing, it didn't work very well. So I didn't get a great implant into her. But yeah, that's I think a bit of a contraindication for it. Okay, so I'm going to move to the lab next.
We have a little break.
Yes. Actually, we have a break for a little coffee break, and you can see the exhibitors while we get set up for. Thank you.